Good morning. Welcome. This session is about health systems as change agents. And we're pleased to have five speakers. One of them is virtual, and I'll introduce each one as they are introduced to speak for us this morning. So my name is Dr. Daniel O'Neill, Managing Editor of the Christian Journal for Global Health and part of the Health for All Nations Institute. Today, the first speaker we have today, we're going to discuss health systems and how that is perhaps how that relates to being salt and light as Christians in the world, and there's various different types of systems that we'll get into today. So we're going to save the Q&A to the end. So we'll have the first four speakers speak from here, and the first speaker, pleased to introduce Dr. Hannah Ndungu, who's the Director of the Emergency Management at ADRA, Africa Regional Office, and out of Kenya. And she's speaking about integrated health systems and livelihoods in refugee settlements in Kyaka-Uganda. Welcome, Dr. Ndungu.
Thank you and good morning, everyone. Thank you for the opportunity. I'm just going to go straight and make my presentation. Integrated health system and livelihoods refugee settlement in Kyaka-Uganda. And I'll start off by also introducing Adventist Development Relief Agency, which is an agency globally. It's operating in 118 countries, and in Africa we are covering 34 countries in West Africa, Eastern Africa, and Southern Africa regions. And our mandate to reach out to people who are in distress is drawn from the book of Matthew 25:35 to 40, rooted under justice, compassion, and love. And every action matters in the lives of refugees that we work with, and especially in the absence of various basic services such as food, health, and shelter. And ADRA has been working in various refugee settings in Africa. Now, I want to talk about the refugee settlement in Uganda, more specifically in Kyegegwa district that hosts about 134 refugees, 1,000 refugees. But before that, we know Uganda hosts 1.8 million refugees in different settings, as you can see here in the map. Where there are various numbers of refugees, and 51% of them are women and girls, and 57% are children. And there is limited health, education, wash, and food insecurity that has continued to increase the vulnerability of the affected population. In fact, the report on food security and nutrition says 61% of people or this household in these settlements are food insecure. And that gives you the background of what I'm going to present, which led to ADRA setting up a health system in Kyaka, in western Uganda. This is a health clinic that was set up to address the health needs of the huge number of refugees who are arriving in Kyaka. Even up to now, the numbers continues to increase. And this health sector was set up because of the needs of health issues that are growing at in this location. The refugee, there are only 2 organizations that are addressing health. And you can imagine then addressing 134,000 people. We have Medical Teams International and ADRA. And the facility at ADRA can manage between 100 to 200 people per day. And the cases of malaria and respiratory infections are the most common consultations, ranging between 35% outpatients. There is a serious challenge in terms of access to medicine, which is hampered by these funding cuts, and most of the partners who have been supplying us with medicine, they are no longer doing that. So then we also have an assessment that we have conducted where more than patients spent more than 2 days waiting to see a doctor. And they can also line up for 6 hours to seek for medical help. I'll just jump this. These are some of the major illnesses that are treated there at the center. And we are also working with faith-based faith-based leaders to support us with psychosocial program, supporting the refugees in counseling and other services they require. And we have also trained the refugees leaders on basic counseling sessions so that they can reach out to communities. We are also supporting issues to do with SGBV and working with various actors where case management is needed for referral. Now, partnership connection is one of the primary strategy we have adopted to take care of the needs of health, and those are some of the partners we are working with, the government, Ishaka Hospital, UNHCR, and others. And within this, we have also integrated, just next to the health center, we have 2 acres of land where we have set up agricultural training center to train the community on kitchen gardening, climate smart, health and nutrition, cooking demonstration, and all that. And we are also working with Makerere University so that whatever research they are doing is going to support the refugees community and the host community. Now, this approach, we have applied 3 integrated health livelihood approach. That is food security, shelter, and health services. The 3 areas covers the resilience adaptation pillar, where we want to see the refugees getting assistance on cash transfer programming, which we do, and they are able to reach out to go and get medicine or whatever help they require in terms of health and food. We also support them on social behavior change, on how they need to look at positive health behaviors to avoid health issues. Adaptive climate agriculture, and also transformative issues that we have supported this community. Now, I will not go straight to the challenges because of time, but you can look at them to see how we want to navigate through the issues that are happening around humanitarian architecture. But I want us to listen to this short video that will give analysis of what, just a quick overview of what we are doing in this clinic. And I just hope it can play around. Would you like to click there?
Nachádzame sa v zdravotníckom zariadení v utečenskom tábore tu v Ugande. A dneska v tejto našej nemocnici je viac ako 200 pacientov. A prišli sme sem, aby sme povzbudili týchto ľudí, aby sme tiež poskytli nejakú pomoc.
Thank you so much, Stano. My name is called Dr. Maweje Saul. I'm a medical officer and also a facility in charge here. We started last year in June. We are happy to be here because we are serving a lot of people, as you can see. And the most common disease here is malaria. It affects all age groups, including the pregnant mothers.
Okay, so you have some patients, so we have to go.
Yes. It is a health center. It provides a limited number of services, a general outpatient service. Someone comes from home, we treat, and then they go back. Some bit of laboratory services. We provide family planning services, immunization services, some bit of nutritional services. The services are free of charge. The patients don't pay for any service.
All of those dots you see are malaria parasites. And around 60 to 70% of the patients who have here have malaria, which is so dangerous and can kill children, pregnant mothers, and all other people who may not be successfully treated. The one with 3 bands have more than 2 species of malaria.
Here are our drugs. Some of them, they are out of stock. Some of them, see, there are few. And this has been for normal saline.
The major constraints we have is the consistent supply of medicine and laboratory use. Sometimes we have, sometimes they get over, yet we have a high number of patients who need these services. We also need a sponsor, because right now the project is closing. We are only 8 staff which work on almost 200 patients per day.
Som Veronika, som študentkou 5. ročníka medicíny. Vďaka humanitárnej organizácii ADRA som sa dostala do nemocnice v Čake. Každý deň sem prichádza skoro 200 pacientov, avšak videla som dosť z nich, ktorým nebolo možné pomôcť hlavne pre nedostatok liekov alebo vybavenia. Musím povedať, že som tu rozhodne zažila tropickú medicínu. Veľmi veľa prípadov malárie a dokonca aj brušný tyfus.
My name is Gracious. I'm the mother. I'm the one who's sick. The presence of this hospital here, for sure, it's helping. Because before we used to go up to the Bujubuli. It's far from where we are staying. Most of us, we are just around.
Thank you, doctor, that you are working here. You're welcome. Because those people are needed. Yeah.
Thank you very much.
Thank you, Doctor. We have now Yasmine Vaughan, who's a technical advisor for Global Health and Mission. And she has, I don't know if she's the sidekick or she has a sidekick, but that's Molli Goetz. Did I pronounce that correct? LMSW, Monitoring and Evaluation, Healey International Relief Foundation. So welcome. They're going to speak about the power of collaboration to bring about health system change. And they're speaking about their experience with programs for continuous medical education and health system resiliency. So welcome.
Good morning, everybody. Thank you, Daniel, for that great introduction. As he said, our presentation today centers on the health system strengthening work being done in collaboration between our organizations and the Christian Health Association of Sierra Leone, which is a part of our 30 by 30 health system strengthening initiative through CCIH. We have 3 objectives for our discussion today. First is to encourage you all to collaborate with other organizations to achieve these big goals like health system strengthening. Second is to share a little bit about our maternal and child health training work, which is a program that we believe has a lot of potential for Christian organizations to do to improve maternal and child health from a health system strengthening approach. And then last but not least, to highlight how this training can have the impact of inspiring change agents around the world. Oh, perfect. So I won't go through all of the partners on this slide like Hannah did as well, but we take a systems approach to this, and we work with a variety of partners at every single level. So everyone from the top at the Ministry of Health and Sanitation to the little local facilities in rural areas that carry out this program. And what we really want to talk about, though, is the power of empowerment and how we go about doing this work of collaborating with other organizations. So I want to quickly share some of the shared values that we have, that we believe have to be present in order to collaborate with others. These are qualities that I would encourage you to not just look for when you're embarking on collaborations, but to embody yourself in terms of carrying out global health change. And so at this conference, and I think generally, we talk a lot about collaboration. Oh, we need to work together. We need to work together. And, I think especially this week, we've said, in light of all the changes that have happened, it's more important than ever to do this. But I think we rarely actually do the hard work of collaborating with other organizations. And I think the reason for that is because we don't always feel that we have these qualities in place. So I think these are the ones that are the most important to have when it comes to a collaboration. This is what we look for in people that we look to collaborate with. Some of them are pretty obvious. We want to look for someone that wants to actually work collaboratively with us. We want to make sure that the roles that each organization is playing are clear. We know who is doing what, we know who's going to be responsible for what, and that people are actually going to take that responsibility. Communication and trust, important in any relationship you embark on, but especially important when the people that we serve are so vulnerable, and the support that we give is so important. I think the two that are probably the hardest, but are possibly the most important, are having a sense of shared ownership. So in our maternal health training, you saw on the first slide, we put everybody's logo on there. It isn't just us that's doing the work. Whenever we talk about the training that we do, we always mention our partners. We always try to tag them on social media because we see it as our project, but we also see it as their project too. And we want to make sure that that is always being shared and that people are always aware that we are willing to share and be collaborative in that way. It is important to have your logo on things so people know who you are and know what you're doing, but it's also important to promote the work of others when you're working together. And with that shared ownership, you also have to take responsibility for the successes together. It isn't just one organization that succeeded, but it also isn't just one organization that failed. And so you have to be able to take that responsibility as well. The last one, separating finances but sticking to commitments, I think is another reason why organizations don't want to collaborate. They get a grant for a specific project to do a specific thing, and those aren't things that you can share in terms of grant funds. However, when we do our project, we keep our finances separate. We develop a global budget that applies to everyone, and organizations specify what they are going to fund and what they are not able to fund. And we find ways to collaborate and fill in the gaps, and we make sure to hold each other accountable to filling those financial commitments. So now that we've talked about how organizations collaborate, I want to talk briefly about why we chose to collaborate on a midwifery training project. There's a lot of different statistics on this slide. Most of them are on the World Health Organization website, so I won't bore you by reading all of them. But the gist of it is that the world needs skilled midwives. The WHO says that skilled midwives could avert 80% of maternal, newborn, and stillbirth deaths. However, skilled midwives is the key. And for a variety of different reasons, midwives need support to be skilled. In Sierra Leone, which is the project that we're going to be talking about, there is no mandate for continuous medical education, which means that midwives, once they are trained, are just sent out, and they're never retrained, they're never recertified, they never have a chance to practice their skills before they're dealing with patients. And that leads to not just a loss of competence, but also a loss of confidence in their ability to do the skilled work that they need to do. So I'm going to turn it over to Molly for a few minutes to talk about this project that we collaborate on, what it actually looks like, and what the results of this collaboration are.
Thank you. Okay, so the central piece of our work is providing a training conference that most recently happened in January. And when we're designing the curriculum for this training, we focus on promoting sustainability. So the foundation of our training is an evidence-based curriculum developed by JPIGO and the World Health Organization. But we supplement this curriculum with a focus on skills cascading. So we do that by selecting high-performing trainees at each conference and provide them with additional training on how to effectively train others in their clinics, and then provide them with resources and guidance on how to do low-dose, high-frequency training in their facilities. And low-dose, high-frequency training is a model of using short, focused training sessions delivered at the facility level with an emphasis on hands-on, skills-based learning and team-based learning. And there's a lot of evidence that shows this effectively increases skill retention and confidence retention over time. We also have added additional sessions on topics that we know are important for sustainability. So recently that has included talking about perinatal mental health, providing respectful maternal care, and self-care for the healthcare workers themselves to prevent burnout. And this is all with that eye on sustaining the impact of our training. We also care about being accountable, so we carefully evaluate the process through which we're providing training, the immediate outcomes, and the impact of our training. So I won't go through all of our measures and tools here, but if you're interested, we'll have a QR code at the end with a link to our final report. But we specifically evaluate the high standards that we're holding our trainees to make sure that we are keeping very high standards to who gets officially certified, and our certifications are recognized by the Ministry of Health. And we're proud to have achieved very high pass rates at our last training that you can see in our conference report. But our immediate outcome is so far we have 120 certified, recognized midwives and nurses throughout Sierra Leone who've been certified, and 24 rising trainers who are now supporting to be change agents in their facilities. So we're monitoring their implementation of low-dose, high-frequency trainings in their home facilities through a WhatsApp group and constant communication to see the skills cascading out to other healthcare workers. With that, I'll turn it back to Yasmine for one specific case study.
Thanks, Molly. So Nurse Aisatu, her last name is Baby, oddly enough, but I don't know if that's why she became a midwife, but she is a shining example of how investing in midwifery training can create this ripple effect of positive change. So Aisatu's journey began with us in January of 2024 when she participated in our first maternal and newborn health training. She not only excelled in the training, but she demonstrated exceptional leadership qualities and teaching abilities. And so following the training, we gave her supplies and materials so that she could deliver the training at her facility in that low dose, high frequency way that Molly was talking about. And so she led trainings for her fellow midwives and strengthened maternal and newborn care at her facility. And then this year, the pictures at the bottom are her joining us as a trainer in Kenema. And so we got to see her step into the role of a full trainer and sharing her experience, guiding fellow nurses and midwives. And it was really just an inspiring testament of the power of capacity building and mentorship to creating change agents. So by equipping local change agents like Aisatu, we're not just improving individual skills, but we're building this network of empowered healthcare providers who can continue this life-saving work for years to come. So I know we're running out of time. So very quickly, Molly and I could talk about this for like hours and hours and hours, but instead you could read our conference report with our latest training that we did in January. If you're interested in reading our 2024 report, which is 30 pages longer, you can also read that one as well. And we're happy to send that to you. Helping Children Worldwide, my organization, has a podcast, and we've done 2 episodes, one with the nursing and midwifery officer for Sierra Leone, and then an episode on perinatal mental health that you can also check out as well, and we'd be happy to have you. And then lastly, I just want to say, our ultimate goal with this presentation is to inspire a collaborative spirit. It is just Molly and I up here, but we're representing like 19 organizations that came together to make this training possible. And if you have that collaborative spirit, we'd love for you to join our Together for Global Health Network, which meets together once a month to share ideas and work together. And we hope that you will consider investing in training midwives as a powerful method to strengthen health systems and impact communities at a grassroots level. And by doing so, not only will you improve health outcomes, but you will also inspire midwives like Aisatu, a new generation of change agents within those communities. Thanks so much.
Thank you, Yasmine and Molly. Appreciate that. We're going to change the order around a little bit. Our third presenter will be fourth, and our fourth will be third. And the first will be last. Patricia Kamara is the executive director of the Christian Health Association of Liberia. She'll be speaking on implementing community health insurance in Liberia. Community health insurance she'll discuss here, and we welcome her to teach us about this intriguing process. Thank you.
Okay. Say good morning to all. Yeah. Say good morning to all. Yeah, okay. Oh, okay. I'm grateful to be here, and we'll be presenting on tackling financial barriers to healthcare access in rural Liberia. I want to talk a little bit about CHAR. CHAR is an organization that was established in 1975, has 85 member health facilities, 7 hospitals, 11 health centers, and the rest are clinics. Our thematic areas are the drug and supply of medicine to member facilities, and then also training and infrastructure improvement in our member health facilities. Some of our achievements, we have been the oxygen refilling plant that is now operating. We have 2 drug depots, one in this capital and another one in the rural area. And then we will also provide training for our, so we provide training for our member health facilities. As you can see, one of the training there is the dispensers. We realized that most of the dispensers weren't trained, so we have a very intensive training for them. We also work with our communities that are in the catchment area of the health facilities. We work with them so that they can be able to access the health facilities. And when it comes to Liberia, we have a war that took 14 years of war, and this had an impact on the lives of our people. Right after the 14 years of war, we also had 2 years of Ebola experience that took the lives of 1,590 lives. And this has created an enormous challenge for our people. Majority of our people cannot even have a meal for $2 a day. It is very difficult. 37% of our people face increased financial strain due to health expenses. 3% of Liberians have health insurance, and these are people that work only in the mining area. 46% of our healthcare costs are paid directly by individuals from the pocket. So what is the problem? We realize that sorry, I'm not even thinking, sorry. Okay, so I think I'll go from here. Yeah, so the problem actually is lack of insurance coverage for our people, especially those in the rural area. They are not accessing, they don't have access to insurance. That's a problem. Out-of-pocket spending is huge, it's very, very high. And because of this, most of our people decide to go for the basic needs than focusing on the health aspect of it, to pay for bills, health care. Instead, they think about looking at the basic needs. And this is a problem for us. So as an organization, what did we do? We decided that there must be a way to change, to have the people have access to funding. What is it we can do? And the number of years has already impacted them. They are so much depending on support from international partners or the government. So we need to find a way out. What can we do to be able to help these people? So with that, we introduced an approach called SALT. Thank God we talk about SALT today. So SALT here, the S stands for stimulating the community or supporting them to be able to identify those resources that are in the community that they can make use of. So they stimulate them And then after that, they let them appreciate those resources, make a plan on how to implement, to use the resources they have. And then with that, when they have appreciated it, learning and put it into practice, they pass it on, they transfer that to other diseases that may be in a community that they want to solve, or even to other communities. So this method has worked. It makes the community to have ownership of their work they are doing, and it's more sustainable. If you look, we have an example here. This is called the Be Better Club model. This one was established in one of our mental health facilities because the hospital cannot refuse a patient when she went to deliver. You just have to accept them. So they decided that, okay, let's get a few women together, put them together, and then let them, child will give us a C-form, we get a C-form of $100, and then with that, they began the loan program, saving program. When they started this, they found out that a lot of women started coming in, and this loan was given to them about 5% for interest, and it was payable within 3 months. With this, they decided they could use it to pay for income-generating activities they wanted to do, or even to cover their medical costs. How did it work? Monthly meetings, they met and decided who all wanted loans. They gave them loans. Those who wanted to use it to create start a business, they could start a business. But in this gathering, at this meeting, they will also create awareness on how a pregnant woman should care for herself, what are the kind of food she should eat, how can she be able to take care of the family in the home, or even talk about child spacing. And also, they gave them maternal support packages. If it was about time for you to deliver, they gave you a Pampers, some other things that you can use to help you during the delivery. They also did skill development. This one, those that were interested in skill development, they recommended them to other partners, and then they were able to provide that training for them. Because of the way it was going, the program expanded from just pregnant women to also including the spouses of these women, and then also other women that were not even pregnant. If you look at what are the achievement, financial growth, and services, from the $100, the amount went to $2,150. When we talk about community advocacy and awareness, we look at it that it has improved the community. The community is not only seeing maternal issues as individual thing, but they take it as a community as a whole. And to improve the maternal health outcomes, 60% of these women that were involved in this club are not delivering at a particular health facility. They don't have to worry about paying bills, delivery, or bills after delivery. No, they don't worry because that money is there. And membership has expanded from 7 women, it has gone up to 100, just from the period of 2021 to 2024. In conclusion, this club is an eye-opener for many people. It shows that if the community are together, there's a lot they can do, especially when you have to educate a woman or her family, and then also provide some support. They are now focusing on extending it to other communities just so that there can be more impact within that community. I want to say thank you so much.
Great. Thank you so much, Patricia. Our final speaker is Dr. James Dua, the Deputy Executive Director of the Christian Health Association of Ghana. Let's hear more about James. Hold on. I think he's going to join us too for the Q&A, so virtually. Anyway, he's the Christian Health Association from Ghana. He published in our journal with Peter Yoba in 2017. So he's here and he's among us, as God is.
I'm very excited to join you for this year's CCIH annual conference. In the next few minutes, I'll be sharing with you Chuck's experience in leading quality improvement in Ghana that has led to the adoption by the Ministry of Health for all facilities in Ghana. Now, literature is extensive on quality of care. WHO estimates indicate that about 3 million people die annually around the world from unsafe care. And indeed, people have wondered if 1 in 10 patients are harmed in the process of seeking care, then why the need to seek care? So why and how did we start our quality improvement? We noted that government had on its agenda to promote medical tourism. We are surrounded by countries that have conflicts and instabilities and disruptions in their health system. Secondly, the Ministry of Health had developed a strategic plan 2017 to 2021. The review was done about 2 years ago, and it showed that there wasn't much progress on quality. And importantly, the leadership of CHAG had personal experiences on unsafe care. Unfortunately, I lost my twins because of unsafe care, and our executive director, Dr. Peter Eboa, also had similar experiences. Now, these were reasons to invest in quality of care, not just for ourselves, but also for our country. So in 2019, together with pharmacists, we launched this innovative program on safe care quality improvement. And our objectives were to measure, rate, and benchmark quality of care in all CHAG facilities and build capacity of our people to lead quality improvement program. Now, because we are a faith community, let me emphasize that one of the biggest threats for faith communities around the world is actually when government build institutions and they don't need us anymore. So the reason why government will continue to use us is when our services are of quality and patients will have no choice than to use our system. So this also became an issue of sustainability for our faith system in Ghana. So what did we do? We selected people from across different professions, nurses, doctors, pharmacists, and we brought them together. They went through very rigorous selection and went through training to international certification level. At the end of the period, 30 of them became internationally certified safe care assessors. And they were used to assess all our facilities across the nation. So the pictures that you see here, this is a Reverend Minister who's an internationally certified safe care assessor. She and other colleagues went around all the nation assessing facilities to see their state of care. They identified gaps and sat down with facilities to develop an improvement plan and then followed them up to see implementation of their improvement plans. Now, the picture you see here are the 28 certified safe care assessors. We bring them together from time to time, review the program. They give us feedback on how our facilities are performing and plans to improve the system. Specifically, what do facilities do? We have 170 indicators cut across leadership and governance, human resources, service delivery, safety. So they first do self-assessment, and then we send the certified assessors to on-site to do assessment. They identify gaps, sit with the facilities, and then do planning and implement what the plans are. We provide them with digital support systems that give them real-time access to progress on what they are doing on quality. Again, they get feedback and what to do specifically to improve their health services. At the end of assessment, every facility gets this plaque that says that this facility is on quality improvement journey with safe care, and their levels of rating is indicated at the facility. Now, safe care is accredited by Joint Commission International, COSASA in South Africa, and ESQA, which is the highest accrediting institution in the world. There are 5 levels, so level 1 to level 5. Level 5 means that the facility has systems and structures and processes to be able to self-detect errors when they occur and correct itself. We have chalked very significant successes since we started our program. All CHAG facilities have been objectively measured
rated and ranked. The good news is that when we did our second assessment, 91% of all our facilities had improved on their health services, and about 68% of them have improved and moved on from one safe care level to the other. Even more important is the fact that 39 facilities have progressed from various levels to level 4. When we started, there were only 4 facilities at safe care level 4. So the picture you see here actually shows the various levels. So we started with a lot of facilities at level 1. When we did the reassessment, most of them had moved from level 1 to the various next levels. And as I mentioned, we have now 39 facilities at level 4, which is really good for us. For the first time in our 57-year history, we have had 5 facilities upgraded to secondary levels by National Health Insurance Authority and Health Facilities Regulatory Authority in Ghana. Health Facilities Regulatory Authority, the accrediting institution in Ghana. They've upgraded this institution to secondary level, which means that they receive higher tariff. This has never happened in our history. We've seen also increased capacity of facilities to do research, and we have quite a number of facilities having many doctors now compared to previously. Some of them have as many as 50 doctors, which is really good for us. MasterCard Foundation, University of Toronto, and Kwame Nkrumah University of Science and Technology for the past 3 years have been running a program on quality of care. They sample facilities from across Ghana, so government, quasi-government, private, and child facilities. Consistently in that program organized by MasterCard, child facilities have been leading in quality of care performance. We've also had a number of institutions that have done research on this program. University of Ghana Business School, University of Ndungu, and others have done research. In all of them, they found very strong correlation between quality level and service utilization. So we have seen that our facilities that have higher levels on safe care have increased service utilization, which in business-wise means more resources to provide care. Now, there's also improvement across other aspects of services. So there are 13 service elements. Apart from service delivery itself, leadership, human resources, management information, laboratory services, and risk management as well. As you can see, in all the 13 service elements, there's improvement in the subsequent assessment. Again, we have also seen improvement in operational and business efficiencies across our system. Stock management has really improved, customer care has also improved, as well as infection prevention and control, amongst others. Now, 3 years into our implementation, Ghana Health Service leads a program called peer review mechanisms. Now, child facilities are part of it, and they noted that our facilities were performing well. So the service decided to let some of its facilities join the Safe Care program. So the picture you see here is the former Director General of the Ghana Health Services with the Executive Director, Dr. Peter Eboa, and Dr. Masuelenchi, Country Director for Pharmacists. They went around to see some of the Ghana Health Service facilities that had onboarded on the Safe Care program. And they were impressed about the performance of those facilities. And that's why you see that infectious smile on the face of the Director General of the Ghana Health Services. Now, in the regions where Ghana Health Service facilities have onboarded on the program, these are regional directors for those facilities. All of them have seen the impact of safe care on their facilities, and they think that is really good. Last year, we had a real opportunity to share on the biggest health platform in Ghana. That's the Health Summit. Health Summit in Ghana is a coming together of government agencies, donor partners, and all Ministry of Health agencies to review the health sector in Ghana. And when we shared our performance and improvement that we have seen on our program, there was a very unanimous decision. The government decided that all facilities in Ghana, whether you are government, private, mission, quasi-government, should go on the Safe Care program. So it actually appeared on the aid memoir for the government saying that our facility should go on our program, which is really good. Consequently, following the documentation in the aid memoir and the government decision to scale up Safe Care to all facilities across the country, this imposing facility has been built at our headquarters, at CHAG Safe Care Hub, and that is where quality improvement is coordinated for the scale up to all facilities across the country. We have actually recruited directors, managers, and other staff, supporting staff who are leading this process at our head office. This is the conference room, and we have several offices where staff occupy to lead that process. The program has not been without challenges. First is the long distances that our Safe Care assessors have to travel to do assessment. As you can see, some of them cross rivers in order to be able to get to facility to do assessment. There are places that the roads are unmotorable and difficult to reach areas that people have been crossing. Secondly, there's no established post on the payroll for government for people who want to pursue career in quality of care. And that's a challenge. Safe Care assessor is not on payroll. So it poses a challenge for people who want to pursue that career. There are also several lessons learned. Assessment without rating does not yield the required commitment and motivation. Of course, the reason why people don't mind paying for a 4-star hotel is that they are guaranteed of the quality. So if you are doing quality improvement and we don't rate and rank our facilities, then what will be the motivation? And since we rate and rank our facilities, generated a lot of motivation for our facilities, for our staff. The second is on leadership, and presence is a leader's act. For this program, we have committed about 70% of our effort, the child leadership. And so you see the executive director of CHAG, Dr. Peter Ebwa, and others. We have gone around all the country on countless occasions trying to do assessment of our facilities and how they are performing on this program. And in many ways, it has contributed to the successes that we have seen on this program. Again, there's a lot of interest from our church leadership. Every year, we present the state of facilities to our church leadership, the bishops. And no bishop wants to see his facility at level 1. All of them want to see progress. So they are highly interested. Of course, the Safe Care programs transcends beyond clinical impact. We've seen significant improvement in operational efficiencies at the facility level, especially on regulatory compliance. Since we started this program, we haven't had any issue with HEFRA or NHIS, and that is good. It's also good to think sustainability right from the beginning. The reason why we actually trained our own people to international certification level is because of sustainability. Can you imagine the cost if we invite, say, Joint Commission to come and do assessment of our facilities? But now our people are trained to do that, and that borders on sustainability. Partnership is also very key. We couldn't have done this without the support of pharmacists. And it goes, I think all of us are aware of the role of partnerships. To end, I want to leave you with these reflections. Why should you pursue quality? And what is the best way to motivate our facilities to improve? The answer is obvious, and it's aptly captured by one of our facility managers who said, healthcare quality with improvement without measure is like giving poison to patients to go and drink and die, unquote. Thank you very much.
Thank you, James. Now, if we could have the speakers come on up here, if you would. Just take your seat. We are now opening it up for questions and answers from the audience. So as anybody raise their hand, and if we have some roving mics that you can pass along, if you can speak into the mic, that'd be grateful. I'd be grateful for that, because we could then have the streaming folks hear what you're asking. Do you have this mic here? Any questions for our panel?
It's about the insurance program that you implemented there. I was just curious if you could give us a little more details on how that works.
Okay, how the insurance program for the Be Better Club works? Yeah, this is how it goes. Child provided a seed fund of $100 to the health facility. After we have created awareness with the health facility on the SALT approach, that is using your resources that you have to make decisions regarding your health to improve your health. So with that, when we give the $100 to the health facility, the clinic, they call these women to come together to say there's $100. Can we have a club that will be want to use this money that will serve as a saving? You can borrow, and then with our interest added, after 3 months you pay. But this money you're taking, you can either use it to pay for your medical bills, or you can use it to do that income generation project that will bring in more money for you. So that's how it started. So every month, the first Friday in the month, they go for this meeting. Those who want to take a loan, they take the loan. Those who have brought back some of the money they took earlier, they pay that. And then also in that meeting, they create awareness about their health, how to take care of themselves and their children. So that's how it works.
One last question then.
Yeah.
Is there sort of an average amount that women tend to borrow?
Is what?
Is there an average amount that the women tend to borrow?
Oh yes. You cannot go above like $20. You cannot go above that. It has to be within that range. And when you take that money, within 3 months you have to pay. If you cannot pay, they have rules that you got to follow. Either somebody will be there to vouch on your behalf to say, hey, this is the time to pay this money. But the clinic did it in a way that there will always be fund for you, especially the pregnant woman. When it's time for you to deliver, the clinic will not have to be able to fulfill that money, but there's money for you to pay. So because of that, a lot of those women go back to that clinic to deliver. Right. Yeah.
Thank you. Thank you. Any other questions?
This question is for Yasmine. It sounded like a wonderful network that you're working with. But I wonder, because I know networks can also be messy, especially when it gets to a certain size. Could you share any of the particular challenges you faced in bringing people together, organizations? I know sometimes when key representatives come and go, or maybe funding issues. But yeah, just love to learn from any challenges that you faced in building and maintaining your network.
Yeah, that's a great question. I think probably the people from CCIH are laughing because they face probably some of the same challenges that we do. Yeah, certainly when organizational representatives that are super involved in the network leave, it's hard to find somebody else who really has that impetus to want to meet together. There's one thing that's really great about the network is it seems like most people are very open to sharing projects that they're working on, sharing curriculum, sharing other things. And I think that space of sharing opens other people to want to share what they have and the resources that they know, the contacts that they know for medical supplies and other things. One area that we're hoping to get more involved in is other organizations collaborating on projects in a particular regional area. And that can be really challenging to do. But honestly, some days the hardest part is, here's the meeting, hope somebody comes.
Okay, thank you very much. I want to make a follow-up question around issues of healthcare financing. I could see from the ADRA's presentation in Uganda that there's a huge challenge in terms of financing. On the other hand, I'm seeing CHAL in Liberia sharing about success. So I looked at also like the population and then I was wondering, because issues of health insurance, which is more sustainable, although not very much available to the rural population, is all about risk pooling. Yeah, so that each and every one of us will give small amounts, and that takes care of our healthcare at some point, because not all of us are going to get ill at the same time anyway. That's the principle. So have you thought of any initiatives of expanding your model into an approach that could reach more people, and how, what are some of the bottlenecks you're facing around that? Thank you.
I think the Be Better Club model is just one we have talked about, but there are several other projects that we implemented similar to that. For example, we give the community seed fund, and they use this to plant a cassava farm, and then the seed from this cassava farm is placed at the health facility. They don't use it, but it's placed at the health facility. And any of the members that are within our community go there for treatment, and especially the focus on maternal and child health. If you went there for treatment, you have to use specific amount, but at the end of the day, you have to make sure that that money is replaced. So that is also working in one other community. Another community, to make sure that the funding that you are taking is being replaced, they have specific rules to say, hey, if this person comes for the funding, please, who will vouch for them? And because of that, they are very strict on bringing back that money. So as a result of that, because the fund is always available to solve those issues, a lot of people are getting interested in opening their own club. Some of it they call it like susu. You bring in the money, and then at the end of the day, that money is divided at the end of the time set. But at least it is there to solve problems.
Maybe to add on that, in the case of Uganda, the refugee settlement, what we have done is to build on the capacity they already have, and promoting VSLAs, Village Learning Association, and also digitalizing it for the youth to be interested to do it. So this has supported the groups, the women groups, the youth groups, where they are taught how we train them on literacy financing. And that way they are taught how also to save some money to pull back in their basic services. So that's an activity that we are really doing, so that they are able also to take their own initiative in terms of financial management and being resilient on their own.
Thank you. We do have to close it up. We just for the sake of time, just to summarize. I mean, I think, just to remember that health systems are really not the change agents. That God is the prime mover through this. We heard about this morning at communion. The people who are yielded to God's presence, like yourselves, and allowing Him to work through you to affect transformation as change agents in God's hands, and there are manifestations of God who heals. That's what systems that are well designed for flourishing is a manifestation of God who heals, and who creates order out of chaos, and who brings all the fractured parts together in a harmonious whole. So St. Teresa of Avila wrote, "Christ has no body now on earth but yours, no hands or feet on earth but yours." So these five servants have shown us how God is working through them and their organizations to build God-honoring and people-blessing systems. And as Psalm 118:23 says, it's God's doing, and it's marvelous in our eyes. So would you join me in thanking these five speakers, and also join me in a word of prayer. Father in heaven, we thank you so much for these servants of yours who are engaging with your empowering work of being light and salt in their communities and in their health systems. We pray that you would continue to bless the work of their hands, that you would be glorified and honored, that the people of the world and all nations would be blessed. And we ask this all in the name of the Father, and the Son, and the Holy Spirit. Amen.